right, I think we're going to go ahead and get started. We don't have too many people on yet, but there's usually some people that come on, and nobody likes to get up early, but if you're interested in passing the boards, it might be a good idea to consider that. Anyway, we're going to go through some cases. This is where I'm just basically going to kind of go through and give you some what I do when I look at slides and how I approach it, so you can go back, view this over and over again, use the information. So when you're studying, you can go through this. I highly recommend when you look at any slide, I don't care how good you are or how good you think you are, that you apply criteria and go through it on a systematic basis. If you just kind of go in and look and start at, shooting answers and things like that, you're going to make mistakes. And when you're taking the board examination, you want to feel confident. You want to go in and know, have a system and an approach that you can work through these cases and whatnot, so that you can formulate an answer. If you just start putting things down and then you start trying to see what's given in the choices, you're going to sometimes be frustrated and start panicking, and then you're not going to be calm. And unfortunately, that's how you end up making mistakes. So we always start off the same way. What kind of biopsy we're looking at? And here we've got a very large biopsy, an excisional or an incisional biopsy. So obviously it was a pretty large lesion, and somebody was thinking they needed to do either a large incision to get a representative sample, or they were trying to remove the entire thing. And we think it's inflammatory neoplastic. And certainly at low power, it looks like most of the cells are small and dark and blue, or have a very dark blue, purple, or black. So there's inflammatory cells in here. So we think it's probably going to be lymphocytic, at least in some way. And obviously, if it's comprised mostly of lymphocytes, it can be an inflammatory lymphocytic process, lymphocytic infiltrates, or a condition that causes a lot of lymphocytes to come into the lesion, or it can be a neoplasm of lymphocytes, like a lymphoma. So you always just want to keep that in the back of your mind, when you're looking at something. You say, well, if this was an inflammatory process and they took an incisional biopsy that's, almost looks like an excision of a melanoma, maybe it's not just an inflammatory process. Maybe it's a lymphoid, hematolymphoid lesion. So as we look at low power, you can see that these cells are present in sort of a band-like fashion in the papillary dermis. There's also some involvement down in the reticular dermis, maybe even tracking down that adnexal structure, but it's got that sort of band-like fashion. And as we go to higher magnification, once again, now you see that they definitely are lymphocytes, and they are filling the papillary dermis. That's not truly lichenoid. A lot of people kind of get a little sloppy when they talk about lichenoid inflammation. It really needs to obscure the dermal-epidermal junction, where you can't really see the interface between the epidermis and the inflammatory infiltrate for it to be lichenoid. This isn't really lichenoid. It's more of a band-like infiltrate. And then you look down here, it's actually got kind of a nodular pattern as well. So this is a band-like infiltrate superficially with some pretty dense nodular infiltrate in the dermis. So we see something like that, we would start thinking about the possibility of a lymphoma. And T-cell lymphomas tend to give you this band-like pattern with epidermotropism, like mycosis fungoides. And sort of higher magnification, there's a ton of epidermotropism. It's almost like you had a vacuum cleaner just kind of sucking these cells into the epidermis. There is some spongiosis here. And, one of the things that often comes up is say, well, how can you tell the difference between a spongiotic dermatitis with some epidermotropism versus a true epidermotropic T-cell malignancy with some spongiosis? And you got to look at the ratio, if you will, of the amount of lymphocytic infiltrate to the amount of spongiosis. So here we've got almost a 1-to-1 ratio. You've got spongiotic little, microvesicles here, but you've got also a lot of lymphocytes that are basically filling these little spongiotic microvesicles. That's highly unusual for allergic contact dermatitis or nummular dermatitis, something like that. We just don't see that. So when you get, a spongiotic dermatitis due to an inflammatory process, you may get a few lymphocytes in there, but you may also get some eosinophils and some other cells. You don't get this many cells in there. And then you look to the side, you also see a lot of individual single lymphocytes within the epithelium here, and they're not just confined to the dermal junction, although that's kind of where they start off. They're present pretty much above that, and in some cases almost confluent through the epidermis, like in this area here, giving kind of a pagetoid pattern. So this would be very, very suspicious for MF or one of the MF simulators, basically. And when I'm looking at something like this, I'm first of all looking at the pattern more than the cytology. And some people start looking and say, well, are these atypical or not? It's really hard to tell a small atypical hyperchromatic lymphocyte from a larger one that's a little bit atypical. When you get something like this, I mean, that cell is super atypical, very large, and probably 5 times the size of a normal lymphocyte. And then there's the other cells here that have kind of an epithelioid, almost histiocytoid morphology. So these are really, frankly, quite atypical when you're looking down at the dermal component. But if you're just looking at the epidermal component, these don't have crenated nuclei. They don't look like Sézary cells. I mean, that's probably a mitosis, but it could be in the keratinocyte there. So it's really hard to tell just looking at the cytology of lymphocytes when they're in the epidermis. They do tend to be larger. They tend to give you a little bit more atypicality, but you don't have to see a lot of that. So it's really more the pattern. The pagetoid pattern, the lining up of the cells at the basal cellular broad front. If you do have spongiosis, again, a lot of these atypical cells and the lymphoid cells within the spongiotic foci, those are the clues that you're dealing with something like a cutaneous T-cell lymphoma. And of course, the most common of those is mycosis fungoides that we all know. But there are other cutaneous T-cell lymphomas that can give you this pattern as well. The HTLV-related cutaneous T-cell lymphomas, those also can give you this intraepidermal pagetoid involvement, as you see here. CD30 positive transformation of mycosis fungoides can also give you that pattern. Langerhans cell histiocytosis, not generally this cytology of the cells, but that also can give you epidermotropism. So make sure you kind of know those various conditions that give you that. Now, this is getting into more of a plaque, maybe even a nodule type of lesion of a cutaneous T-cell lymphoma. I believe this lesion said that it was CD30 positive in this case. So this was a case of someone that had a CD30 positive lymphoproliferative condition. Maybe they had MF that CD30 transformation happened. Maybe it was a CD30 positive anaplastic lymphoma that looks like MF, which can do that. So basically, you don't need to know that from a histology perspective as much, but just recognize this pattern, this massive involvement of the epidermis with these atypical cells and these large atypical cells in the dermis here. Now, the CD30 positive disorders, it's possible you could face some questions about that on the exam. Obviously, CD30 positive transformation of MF, they're probably not going to ask you a lot of details about when you draw the distinction between that and just regular garden variety MF, but you do need to know that the CD30 positive transformation associated with worse prognosis. And you get CD30 positive lesions in mycosis fungoides. You get patients that develop lymphomatoid papulosis. They can have lymphomatoid papulosis first and then get mycosis fungoides at 15% of the time. They can have MF, classic plaque patch tumor stage disease, and then pop up with lymphomatoid papulosis along the way. Lymphomatoid papulosis can be associated with CD30 positive large cell anaplastic lymphoma. It could also be associated with Hodgkin's disease. So make sure you understand how CD30 positive diseases are related to one another. And then also I would, recommend just, understanding the various patterns of MF. This is a beautiful example of follicular tropism here. And if you look here, you can see that these cells are very large and atypical within that follicle. So that's another beautiful example of that in this case. So again, mycosis fungoides, CD30 positive in this case, wouldn't necessarily need to tell that from this, but at least you know the morphology and how to work that up and apply your criteria to get the definitive diagnosis there. Okay, now we've got a shave biopsy, different pattern altogether, and it looks pretty much like a neoplasm. And, they shaved it, so they probably were thinking of something like roulette basal cell, roulette squamous cell, something along those lines. First question we ask ourselves, do we think it's benign or malignant? Maybe it extends over to here, but it seems like it's fairly small. Here's another little piece. If that's all we had, that would be quite small. This isn't nearly the large size that last biopsy we had. Seems to be fairly, if we think this is representative of the whole thing, it seems to stop here, so fairly well circumscribed. If you draw a line down the middle of it, it pretty much looks the same on both sides, and it's fairly superficial. We don't have a deep biopsy, but it seems like it's pretty much contained right here. It doesn't have a lot of features that suggest that this is the surface of a deep-seated iceberg, if you will. So looks overall architecturally benign. And again, I strongly recommend spending a couple of seconds at low magnification, going through that, and then ask yourself what kind of differentiation you're looking at as you go to higher magnification. So probably benign. Epithelial or non-epithelial. We see something that looks bluish here. It looks like it's contiguous with the epidermis. We don't see spindle morphology. So we're going to favor this being an epithelial process. And as we go to higher magnification, we're going to confirm that. And then once it's epithelial, once again, we want to ask ourselves which type of epithelium it's recapitulating in the skin. So a lot of people say, well, epithelium, they instantly think of squamous epithelium, stratified squamous epithelium, but you do not do that. Remember, there are a number of different epithelial structures of adnexa in the skin, and that's what you want to ask. Is it possibly follicular? Is it possibly sebaceous? Is it eccrine? Is it apocrine? So you want to go down those pathways and see which of those it's most likely to be. And we can see here these cells are basophilic. They've got these little structures that sort of look like they're recapitulating the hair follicle. That looks like a little papillary mesenchymal body, if you will. So it looks like the papilla of a hair follicle with this little sort of ball and claw-like morphology sort of surrounding that. So that's highly suggestive of either mantle zone differentiation or possibly the inferior portion of a follicle. And notice that this thing is oriented in a horizontal fashion. It almost looks like kind of a plate, if you will. This is a horizontally oriented epithelial lesion with these basophilic cells. And so we start thinking basophilic, is it something like germinative epithelium, possibly something that theoretically could be sebaceous? Could it be eccrine or apocrine, or could it be follicular? And if you start seeing things that look like papillary mesenchymal bodies, or you see clefts between the epithelium and the stroma, like right there, you start thinking about more likely follicular epithelium and primitive follicular epithelium. And so when you think about the hair follicle, we sort of generally tend to think of three parts: the infundibulum, the isthmus, and the inferior portion of the follicle. At the isthmus lives that little mantle zone. And that's kind of a very interesting little stem cell area, because that little zone can lead to a lot of different structures. It gives rise to the sebaceous duct and the sebaceous gland. It gives rise to apocrine epithelium. So that all comes right off of that little area. And it's also the site that the stem cells live when the follicles cycle, and it reforms the new inferior portion of the follicle once it goes into telogen, into the resting stage. So given that, it can also form these primitive follicular lesions. And so knowing that this is oriented in this horizontal fashion, it's got these little plate-like aggregations of these little primitive follicular-like structures that look very much like the stem cells of the mantle zone. This is a classic example of a lesion known as the tumor of the follicular infundibulum. And a lot of these names were given to these entities years and years ago. And so this really isn't the infundibulum of the follicle. The infundibulum, which also, it means funnel, it's a Greek word for funnel, that's the part of the follicle at the surface, and it's lined by stratified squamous epithelium. So it's not really, doesn't really have these germinative epithelial structures like you see here. So this is a little small infundibulum of a follicle right here, if you will, and that's lined by stratified squamous epithelium, and so that's going to give you a different morphology in this. So really, it's a misnomer. It's not really a tumor of the follicular infundibulum. It's actually kind of a tumor of the mantle zone. And there are a lot of different benign adnexal neoplasms that can occur from that mantle zone area. Probably the others that are the most important are things like fibrofolliculoma and trichodiscoma. That also arises from the mantle zone area in patients with Birt-Hogg-de-Bay. But this is a beautiful example of TFI, and they could show you this on the board examination, expect you to get it. It's not a real common lesion clinically. These are usually thought to be, things like maybe verrucae or seborrheic keratosis, or maybe rule out basal cell, something like that. Clinically, they kind of look like usually a skin-colored or slightly whitish to pink papule, and it's usually small and round. They kind of almost look like a little verruca or seborrheic keratosis. Other entities that can kind of look a little bit like this are things like trichomonas trichromoma, because this is sort of looks a little bit like tricholimal differentiation or tricholimal verruca. That's not used, it's not horizontally oriented like this, so that's usually a small, round, vertically oriented type lesion. So it looks a little bit different, but it's a similar type of epithelium. So this is recapitulating primitive follicular epithelium, and some of that does look a little bit like the outer root sheath of the hair follicle here. So tumor follicular lymphedema, totally benign, not associated with any syndrome. Just make sure you can recognize this. And, if they had this on a multiple choice, they might put in something like a seborrheic keratosis or superficial basal cell carcinoma. Look for the follicular differentiation, obviously not typical of a superficial basal cell carcinoma here. All right, number 3. Take a look at this one up here. And let's see if we can find this area right here is probably the best one. Okay, I'm going to punch biopsy here. And at low magnification, we really don't see a lot of inflammation. It's pretty sparse. We do see a lot of erythrocytes here. And sometimes that can just be coincidental from a biopsy. But, you should think about, well, let's make sure that those blood vessels aren't thrombosed or something along those lines. Let's make sure it's not a vascular neoplasm that they did a punch biopsy on. But it's a pretty sparse infiltrate. There's something going on at the epidermis. We're going to look at that at higher magnification. There's a little cleft there. That could be artifactual, but, it could be there for some reason. And maybe there's something going on in the fat here. So at low magnification, really all we can just kind of say is a pretty sparse perivascular dermatitis, maybe a little bit of a lymphocytic infiltrate, a little bit of alteration of the epidermis. We're not really 100% sure of low magnification. All we can say for pretty sure is that it's unlikely to be a neoplastic process. So let's go to higher magnification. Let's take a look at those blood vessels and see if there's anything really wrong with them. And if you start looking at higher magnification, indeed, there is some abnormality going on here. There is some inflammation here. It's pretty sparse. A few lymphocytes, maybe some neutrophils. These blood vessels are chock full of red blood cells. And then we look at the epidermis, and lo and behold, that was not just an artifact. There is confluent epidermal necrosis. See that right here. Every single keratinocyte here is dead. There's some residual fluid in this space here, so we know this is not an artifactual space. It's a real space because there's something in that space. And it looks like there's some neutrophils in there. There's a basket weave cornified layer, so this epidermis was killed relatively quickly. It didn't, have a long time to die because it didn't really have a chance really to make parakeratosis. So something is causing this epidermis to die. We also notice that the collagen looks somewhat degenerated here as well. And so we start being concerned when we see something like this, that there's an ischemic process. Another place you can kind of look for ischemia, and I would recommend you do this, is look at the sweat glands. As you know, the sweat gland epithelium is a rapidly metabolizing cell. Those cells are undergoing an ATP-driven reabsorption of ions when you make eccrine sweat. And so those cells are, if they get ischemic at all, they're kind of like your brain cells. They die faster than other cells. So in addition to having the epidermis that's necrotic, you see that there's also necrotic sweat glands. So that's a bad sign. So this is an ischemic process here. And if you ever want to, let's say that you're looking at something like this, and maybe the differential diagnosis is between, say, an exogenously induced epidermal necrosis, maybe somebody applied a chemical or scratched the area, something like that. If you want to sort of say, well, let's see if is it real or is it fake, and you see necrotic sweat glands like this, it's real. It's almost impossible to scratch and kill your sweat glands down here. This is way too deep for that. So this isn't just a superficial excoriation that killed the epidermis. It actually was due to ischemic necrosis. Let's take a look down there at fat. And so whenever you get ischemia, you say, well, then that suggests the blood supply is altered. It's not working properly. You've got all these blood vessels that have all these erythrocytes that are chock full in them. We'd like to see some fibrin in those blood vessels. So just having erythrocytes that are sludged in the blood vessel, that doesn't mean that they're thrombosed blood vessels. That you can get that with just low flow, but when you get this many of them, it's a red flag. And then if you look here, there's a blood vessel there that does have something going on in it. And there's also maybe some necrotic sweat glands in that area as well. And let's look down in the subcutaneous fat. And now you do see some of these smaller blood vessels. Now there's some fibrin in these small capillaries down in the fat. So this is a thrombotic process. And it's not just getting one or two blood vessels, it's really getting a shower of small blood vessels with fat necrosis and also necrosis of the sweat glands and necrosis of the epidermis. So this is some type of thrombotic vasculopathic process. So there's some sludge red cells, but you see some fibrin in some of those cells as well up there superficially. So we're not sure what's the cause of this in this situation. We start asking ourselves, what are some things that can cause thrombotic vasculopathy? Things like DIC, platelet abnormalities, tumor necrosis, hypernecrosis, calciphylaxis, which is a common one. In order to really make that diagnosis definitively, you need to see small stippled calcification in the fat or in the dermis, and then you also like to see some calcified blood vessels. We don't really see that here. Sometimes it's pretty subtle, and you really have to look at a lot of areas to see it. I don't know, maybe there's a suggestion of a little bit of stippling there, but it's not really enough to be definitive. If they're going to show you calciphylaxis, you're going to see a big, obvious calcified blood vessels. They're not going to show you something like this. So they would show something that you could make the diagnosis, but you should, at least in a case like this, be very concerned about some kind of a thrombotic process. That blood vessel, again, is not normal. There's something going on here. And that, coupled with the epidermal necrosis and sweat gland necrosis, you should definitely be thinking about some issue that's caused ischemia. Coma blister theoretically could look something like this. Usually doesn't have quite the degree of inflammation in that, because most people usually, if they're in a coma and they sleep outside they don't usually only sleep outside for one night. If they sleep for longer than that, they usually are dead. So you usually don't get this degree of inflammation and vascular thrombosis. Then it's usually just epidermal necrosis with maybe some sweat gland necrosis, because it's relatively acute. So this is probably going on for a little bit longer in this patient, because you've got this neutrophilic infiltrate and whatnot that we talked about in the fat degeneration. So again, thrombotic vasculopathy, not sure the etiology. Make sure you apply those kind of criteria, and you can come up with a certainly differential diagnosis. All right, we'll take a look at the fourth case. This one's sort of esoteric, so you're probably not going to get this on the exam, but they might show something like this and give you kind of a differential diagnosis. And so we have a punch biopsy here, and at low magnification, you can say that something's wrong, because it's a fairly deep biopsy, and there's really very limited amount of dermis here. It just kind of goes down into the very upper part of where we would normally see the reticular dermis. They have all this prominent fat down here. So we generally think of things as being either inflammatory or neoplastic, but then there's this third, fourth, and fifth category of lesser commonly encountered entities: hamartomas, malformations, deposits, maybe things that are pigmentary in nature, but not really truly inflammatory neoplastic. So just keep those in the back of your mind. But something like this, it certainly doesn't look inflammatory, so maybe it's a neoplasm, or maybe it's one of these unusual hamartomas. Normally, when you see fat that's sitting up here in the area where the reticular dermis should be, we start thinking of a relatively few number of entities. Nevus lipomatosis, for example. That's something that can maybe give you a pattern that sort of looks like this. Usually those lesions look like a skin tag. At low magnification, when you see them, there are these multiple, almost cauliflower-like lesions clinically, often seen on the lower trunk, buttock area, upper thigh area. Again, that would sort of give you a different pattern than this, which almost looked like this is sort of this doesn't really have a lot of that cauliflower morphology. This might have been a plaque, if you will. But the fat is way too high. The other thing that you would think about is focal dermal hypoplasia, or Goltz syndrome. That's where the fat occurs high up in the dermis. Usually it's up in this part of the dermis. So it's not just kind of at the bottom, it's usually kind of all the way through. And you can get some other abnormalities there too, some abnormal follicles or diminished follicles associated with that. But we can be concerned about some kind of a hamartoma here. And you can see that there is some little bit of reticular dermal collagen left here. And then really minimal other change. So if you're going to see something like this on the exam, they're probably going to put some of those items in the differential diagnosis. They're not going to expect you to look at this and say, this is Goltz syndrome. but they, might say, give you 2 or 3 other genodermatoses and say this finding is most likely to be seen in which of the following conditions. And they might have, say, something like, another tumor, another Poit's-Jager's or something like that, and expect you to think that it's maybe a lentigo when the fat's clearly abnormal up here. They might say something like dyskeratosis congenita, just make sure that you kind of knew what the disease was, but this would be theoretically something that you might see with Gold's. So this was just an example of a fatty hamartoma, has some reticular dermal alteration. One of the things with the hamartomatous conditions like epidermal nevi, things of that nature, we call them epidermal nevi, but they almost always have a connective tissue component to them. So if you have somebody that's got an epidermal nevus and you say, well, we're just going to shave off the epidermal component, the lesion will come right back. So you have to get rid of the epidermis and the dermis. So nevus sebaceous, for example, if you see somebody that's got one of those, say, well, let's just shave that down and see if we can remove it. That doesn't work. It's almost always going to recur because the dermal component of that contributes to the lesion too. So if you really want to get rid of a nevus sebaceous, you have to excise the whole thing. Same thing if you get like a multiple papular type of epidermal nevus. You have to excise it. You can't just shave it off and think it's going to go away and stay away. Okay. All right, here's another punch biopsy. And this one, once again, probably not going to be something you're going to encounter precisely on the boards, but, it does make some good teaching points here. It's a punch biopsy, and say, well, again, what part of the body are we on? And at low power, it's kind of hard to tell for sure, but notice that there are these hair follicles that are deeply rooted in the subcutaneous fat. There's not very many of them. So there's only about 3, which normally, 4 millimeter punch or even a 3 millimeter punch, you should see about 8 to 10. Here we see hardly any. So we know we're dealing with, if it's a scalp, it's an alopecia. Okay, so when we're dealing with an alopecia, we then have an algorithmic approach to how we approach an alopecia. So ask yourselves whether it's, inflammatory or non-inflammatory. If it's inflammatory, where is the inflammatory infiltrate located? Does it target the blood? Does it target the follicles? If it does, which part of the follicle is attacked? Is it attacking only the infundibulum and the isthmus area, or is it attacking the base of the follicle near the hair bulb area? Is the inflammation not targeting follicles? It hits follicles and it gets areas between the follicles. Is the epidermis involved also, or is it just only hitting the follicles? What kind of cells are they? Are they lymphocytes mostly? Are they neutrophils mostly? Are there some eosinophils infiltrate, like we sometimes see, for example, with alopecia areata, and some eosinophils in that? If there's epidermal involvement, is there changes that look like, lichen infiltrate superficially? Is there something that, might look like, say, for example, lupus erythematosus, interface dermatitis with thickening of the basal membrane zone of vacuolar alteration? So here, and then we ask ourselves if there's scar or not. If it's inflammatory, is it scarring? And we used to call things permanent or non-permanent. Today, I think permanent are things like lichen planopilaris and frontal fibrosing alopecia, where the follicles are really replaced with scar tissue. We used to talk about late stage alopecia universalis as being permanent, if you will, but now with the new JAK inhibitors and whatnot, we can treat that and reverse that. So it's not really right to call those permanent anymore. And androgenetic alopecia, treatment for that too, so not really permanent. But if it gets scarring, that can be permanent, and often permanent. And we also ask ourselves where that scarring is going on. Is it targeting the follicle only, or is it targeting areas between the follicle? And so here we can see that there's this abnormal collagen that's diffuse. The entire area here is involved. So it's not just hitting the follicle, it's hitting areas between the follicle. Now there's 2 ways that can happen, but we'll talk about that in a second. If it targets the follicle itself, we start thinking about diseases where the lymphocytes or neutrophils or whatever are homing to the follicle. So for example, lichen planus, frontal fibrosing alopecia, central centrifugal alopecia, all 3 diseases look basically identical histologically. The inflammation targets the follicle. And then if the follicle gets ruptured, secondary to the initial targeting. You can get some secondary perifollicular inflammation with scar, but it's essentially, if you get it in an early stage, like lichen planopilaris, for example, you see a nice example of the inflammation hitting the infundibulum of the follicle and the isthmus of the follicle with a perifollicular fibrosis that develops right at that area. And it's just basically like it specifically targets those follicles in that fashion, as opposed to something like folliculitis decalvans, which gives you a suppurative folliculitis that then ruptures, and then you get suppurative granulomatous dermatitis that just kind of starts marching through the entire scalp or whatever part of the body you're on. If you're dealing, say, for example, hidradenitis suppurativa, which is basically the same process. So there's two different types of inflammation. One likes the follicle specifically, one kind of gets the follicle and just starts going everywhere. So here we've got a lot of scar here. This is a very late stage process. This isn't anything that's acute here. This person, unfortunately, we're kind of looking at a cemetery, and we're not seeing too many residual follicles here. As you can imagine, if you saw this person's scalp, it's going to look like there's scar there. It's going to have no follicles, or maybe just a few kind of little tufts of hair, but we're not going to see large amounts of hair with a little bit of scarring. This is going to be a permanent scarring alopecia that it's not going to regrow. Now, when we start looking at the follicles that are remaining, there are some clues here that might give us some ideas about the diagnosis. You've got these three residual ghosts of where hair shafts used to be. So this would have maybe a little bit earlier in the life of this alopecia. You might have seen some tufts with a few little hair shafts coming out of it. And that's something that doll's hair-like clinical morphology is pretty characteristic of lichen planopilaris or central centrifugal alopecia, which basically histologically looks the same. So it's possible that what this was an example of LPP or CCCA, where you got a severe form with secondary rupture and scar that then just kind of progressed out diffusely through the dermis here. Now, if you just saw this up here with scar, that's just totally late stage scar, I would actually favor something like folliculitis decalvans, that we were at a very late stage of that with residual scar with really minimal inflammation. Normally, we'd like to see neutrophils and some suppuration, but we don't see any of that here. We just see this scar with a few little lymphocytic infiltrate. So we're not sure what this is, but based on these clues here, it's probably either CCCA or lichen planopilaris, and I would almost kind of favor CCCA when it's this extensive and this diffuse scarring that you see over a broad front. Another clue is if you look at the epidermis and you see some epidermal hyperpigmentation, because that often occurs in individuals that are of African-American descent. We don't really see any of that here. So again, that doesn't prove that it's not CCCA, but I would probably tend to favor that. But just realize that even though you get targeted inflammation of the follicles in lichen planopilaris and CCCA, when you get secondary rupture of those follicles and it gets more diffuse, then you can end up with diffuse scar like we see here. This onion skin fibrosis around the follicles like this, that's really very helpful, seen far more commonly in CCCA and lichen planopilaris and FFA than it is in something like, for example, folliculitis decalvans. That doesn't tend to just stay in the follicle long enough to allow that perifollicular inflammation to develop. It tends to get in the follicle, ruptures, and then it sort of starts marching diffusely. So you don't really tend to get that same type of more slowly developing perifollicular onion skin fibrosis like you see with those other conditions in that process. So even though we don't know for sure, we can apply some of those features and come up with a presumed diagnosis. So they probably wouldn't show you something like this and expect you to commit to one of those diagnoses, but at least applying those criteria and those features we looked at, you can say that it seems to fit best with that as opposed to anything else. Okay. We've got a punch, well, probably an incisional biopsy here. They probably felt a dermal nodule down here in the fat. And so everything is deep. So we always talk about subcutaneous nodules. Most, quote, subcutaneous nodules are not subcutaneous. Most of them are intracutaneous, or usually in the dermis. So if somebody comes in with a cyst, you feel it, say, well, that feels like a subcutaneous nodule. Well, it's not usually subcutaneous. It's usually kind of sitting right in this area. When we say subcutaneous, a lot of people are saying, well, it's below the epidermis. So it's sort of a misnomer, if you will. But this one really and truly is subcutaneous. So clinically, cysts are usually dome-shaped. They're usually low-domed, not usually high-domed, but they're usually low-domed, and you can kind of feel them. You see them, if you will. This lesion you probably wouldn't see. This is probably something that was more of a palpation diagnosis. Patient probably came in, got this lump in my skin, doc, what is this? And you feel it, look at it and say, yeah, that feels like that really is deep. So we're not going to be able to get this with a shave biopsy. Even a punch biopsy might not really be adequate here. So we're going to probably have to do an incisional biopsy. And that's what they did here. They might have just gone ahead and tried to excise the whole thing. Looks like they pretty much did that. So once again, we apply our criteria. When things are deep, sometimes we get a little bit concerned about them as possibly being malignant. Like a metastasis, for example, might be a deep lesion, a deep subcutaneous tumor, something like that. So, but not always. You certainly get subcutaneous lesions that are benign, and so you still apply your other criteria. It seems to be fairly well circumscribed here. It's got two little nodular aggregations, maybe a little third one over here. But if you look at this large aggregation, it looks to be fairly well circumscribed, fairly symmetrical. So we'd say probably benign. And looking at low magnification, does it look epithelial or non-epithelial? Well, it's certainly got a lot of clear white areas. And we know what lives down here is the fat. And so we think right off the bat, it may be an unusual lesion of fatty differentiation. And there are probably about 8 to 10 different fatty neoplasms. I used to give the talk in fat neoplasms at the AED and the Basic Dermatopathology Symposium years ago. And I had to kind of run through those pretty quickly in 15 minutes. But there are about 8 to 10 different types of lipomas that you should know some of the general ones. But basically, you look for the garden variety lipoma that you see, angiolipoma, myxoid lipoma, spindle cell lipoma, pleomorphic lipoma, liposarcomas. There's not a ton of them. You can get fibrolipomas. So as we look at this, we go to higher magnification. So well, it's not just a garden variety lipoma because not all the cells are these classic pale white cells that look like lipocytes. Something's going on here in addition to those cells. So maybe this is one of those other types of lipomas. And so when you are going to look to see what other type of lipoma you're looking at, if these are blood vessels and they have little lobular capillary proliferations, and we saw the case of the thrombotic vasculopathy a second ago where the blood vessels were sludged with red cells. There are red cells. They're not really the same kind of sludging of red cells we saw in that lesion within an angiolipoma, but there are almost always a lot of intact red blood cells in the vascular spaces of an angiolipoma. We have some vascular spaces here. They're small capillaries. We don't really see those little sort of tufted like blood vessels that we see with an angiolipoma. So we don't like angiolipoma here. Is it a myxoid lipoma? Well, we want to see spindle cells with mucin. Usually that's a very, very loose myxoid stroma with a relatively sparse fibroblastic component. We don't really see that here. We've got more of a fibrotic component here. So there's collagen. So there's a spindle cell component, and we all know that we have our three classic spindle cell lesions that we look at. We think of it neural, muscular, and fibrohistiocytic. And so obviously the nerve cells are these little thin, delicate fish-like swimming in a very myxoid stroma. We don't really have a myxoid stroma here. We get a collagenous stroma. So, and these don't look like they're really delicate. They look more kind of like they're, a little bit like cigars, but they're almost a little bit more jagged and then they sort of tapered in at the periphery of them. So they don't really look like smooth muscle cells. So these would probably be fibrohistiocytic cells or histiocytes or fibroblasts most commonly. And so when you see collagen plus spindle cells, think of fibroblasts because they're making the collagen. So there's fat here, but there's also what looks like this benign spindle cell component that almost looks like some kind of a fibrohistiocytic proliferation. If you just saw this at high magnification, I say, wow, it kind of looks a bit like a funny, it's not really a dermatofibroma, but some kind of a fibroma. So probably a hamartomatous fat lesion in which we have both fat and we have both fibrohistiocytic proliferation and collagen stroma. So it's not really a classic fibrolipoma, but it's sort of closer to that. And some of these even could there might be a neural component. We do know that we see neural neoplasms associated with fat sometimes too. So it's possible this could be a neural fat hamartoma. And so if you really wanted to make sure that was the case, you probably could stain it, do like an S100 protein or SOX10 or something like that. But the main teaching point here is not really to delve deeply into that. It's just to understand these various fat tumors and realize that you can get the classic lipomas, but then you can get these other lipomas that have fat plus some other components to them. So I think we thought this was maybe possibly an unusual fibroneural fatty hamartoma. So not anything really to be too concerned about, except just to understand that you get these various fat tumors that give you these other components. Now, if you know angiolipoma, for example, that's one of the classic painful tumors. They could end up asking you that on the board examination. They might ask you some of the fat tumor syndromes, Derkham's disease, multiple painful lipomas, Goldenhar's disease. They get fatty tumors in the conjunctiva associated with other elements of that syndrome. Madeline's disease, they get the buffalo appearance of their neck, again with fatty tumors. So make sure you know a little bit about the fat syndromes and the tumors and whatnot that you can encounter in those. Okay, so here we've got a punch biopsy, probably an inflammatory process here. And low magnification, it looks kind of like a diffuse pattern here, and maybe something going on down here in the bottom of the lesion here. So this is one you probably, again, are not going to get on the board examination, but we can learn anything from any biopsy that we get. So we'll just kind of take what we get here. Sometimes our teaching cuts don't show the classic features that we'd like to see on the original one, but there's always something to learn on a biopsy. So inflammatory, not neoplastic. And what's the pattern? Well, there's some perivascular inflammation up here that's pretty sparse, but the dermis is not totally normal between those little aggregations here. So there may be some interstitial and diffuse inflammation also. There's not much fat in the biopsy. It's pretty deep. So it went deep enough to get to the fat, but we're not really seeing much fat. And there's something going on down here too. So maybe something has replaced the fat. So superficial perivascular dermatitis, maybe interstitial, and maybe something going on down here in the subcutaneous fat. That's about all we can say. The epidermis looks pretty normal. So we're going to just, and if we look at the cells, I mean, these are probably lymphocytes, but some of these cells here don't look quite as dark. Maybe there's some neutrophils in there. We're not sure. We're going to see when we go to higher magnification. So as we go to higher magnification, indeed, we do see that there's a pretty brisk interstitial infiltrate now that we didn't really see that well at low magnification. And as we go to higher magnification, these cells are mixed. There's some eosinophils in here. Most of these cells are actually neutrophils here. Okay, so there's a lot of neutrophils, and there's some eosinophils, but there's a lot of neutrophils. There may be some lymphocytes here, but actually, as we go to higher magnification, we see that virtually all of these cells are neutrophils. And as we go to the other area at the very bottom of the specimen, we've got a collection of neutrophils. Basically, and again, this might have been a more nodular, round collection if we had maybe another section. So we got a lot of we got like almost a separative focus here, but a diffuse infiltrate of neutrophils throughout the dermis that we now can see at this higher magnification. So when you see neutrophils mostly in an interstitial pattern like this, where there's a diffuse interstitial pattern, we start thinking of a relatively few number of items in the differential diagnosis. The first thing I would think about would be cellulitis. With this many neutrophils, relatively dense, okay, so I mean, almost the entire dermis is involved here. And there are some EOs, but anytime you get neutrophils, you get some EOs in there as well. That would be that would be my number one diagnosis if I saw this. And then you couple that with the fact that you've got a collection of almost suppuration at the bottom. Maybe this was a localized abscess that had cellulitis off to the side of it, and they biopsied into the lesion. Maybe they wanted to rule out maybe the abscess was a solid area and they thought there might be a neoplasm there or something. I'm not sure why they did a punch. But if you just see the stuff at the top, this really looks great for cellulitis. Now, the differential diagnosis between this interstitial mostly pattern of neutrophils includes several other diseases. The autoinflammatory diseases can look somewhat like this, but in my experience, those generally are not as dense as this, not quite as dense, and those have fewer EOs than this. Interestingly enough, even though this is almost certainly caused by bacteria, pyogenic bacteria like staph or strep, you do sometimes get some EOs in this condition, and the autoinflammatory conditions, which are associated with abnormal cytokines and things of that nature, you'd think they might have some EOs, generally have fewer EOs. So if you see a biopsy of somebody who's got adult Still's disease, for example, you don't see any EOs in that, almost never. You see just neutrophils, and usually it's not quite as diffuse and dense as this. It can be pretty diffuse, but not as dense. So that would favor this being cellulitis, especially given that separative focus at the bottom, rather than one of the autoinflammatory conditions. The other conditions that can give you this interstitial mostly pattern like this with inflammatory cells is urticaria or urticarial allergic eruption. This is pretty diffuse, pretty extensive, and denser than we see in most cases of urticaria, and also you wouldn't get that separative focus. So those are some of the things that you should think about when you get this kind of pattern. So some people call this a so-called busy dermis differential diagnosis. That's fine. If you see the busy dermis, you want to ask yourself what kind of cells are there. Here we've got mostly neutrophils. I would ask myself, how busy is it? If it's pretty sparse, obviously that would tend to favor urticaria or urticarial allergic eruption, or maybe one of the autoinflammatories. If it's a little denser like this, start thinking more like cellulitis. Then ask yourself what kind of cells are there. If they're things like histiocytes, you think of GA. If they're the spindle type cells, both kind of going north, south, east, and west with some mucin, you start thinking about sclerotic edema. Obviously, if they're vascular cells, think about patch stage capsulocytoma or plaque stage KS. If they're neoplastic cells, leukemia cutis, metastatic breast cancer, those are all the kind of things that can give you that sort of busy dermis differential diagnosis. So this was a nice example of cellulitis that kind of arose on top of an area of some residual abscess that was down in the dermis. Okay, this next lesion, kind of one that, dermatology residents don't really learn that much about, but you're going to learn a little bit about it today. So we got a punch biopsy taken from the face. How do we know the face? Got these large sebaceous lobules. It's got some hair follicles that are not situated deeply into the subcutaneous fat. They kind of go down to the mid to lower reticular dermis. It's also in sun-damaged skin, common location for the face to have sun-damaged skin, obviously. So this is probably an older individual. And so clinically, they felt a small papular lesion, and it probably felt a little bit deep to them. So they probably weren't totally sure what it was. Probably felt like, again, maybe a subcutaneous or dermal nodule here. So they said, well, let's don't do a shave, let's do a punch. And it's a good thing that they did, because if they'd have taken a shave biopsy up in this area here, they wouldn't have gotten it, because this is situated down here. So, we do see biopsies that are taken of things like this by shave technique that don't sample the area, and then they just get back a non-specific diagnosis, maybe of macular seborrheic or sebaceous hyperplasia, but the lesion is really located down here. So this is obviously a neoplasm, okay, and it's small. The whole biopsy is maybe a 4-millimeter punch, and it got the entire lesion out. And it's small, well circumscribed, very symmetrical, so it's got all the features of a benign lesion. Does not look like an epithelial lesion at low magnification. I don't see anything that looks like any of the background normal adnexal epithelium or the squamous epithelium in the epidermis. So again, we start thinking of our three main non-epithelial neoplasms that we have to deal with as dermatology residents: neural, fibrohistiocytic, and muscle. Again, there are other things that can give you spindle cell non-epithelial lesions, but those are the three main ones I want you to focus on. So we're going to look at higher magnification, see if we can tell. And just like we did with that neuromuscular fat hamartoma a minute ago, we now look at these cells and see what we think here. And here we do have like schools of fish that are swimming in this stroma it's kind of pink and bubblegum-like, and it also has got a little bit of mucin over here. So we start thinking this is probably going to be neural. Okay, neural. Now, when we're dealing with neural, there's two main types of neural neoplasms. There's those that really come from the Schwann cells, the sustentacular cells that make myelin on the outer portion of the nerve, and then the axons, the cells themselves. So they're either neuromas, if they're comprised mainly of the nerve, the axon part, or they're Schwannomas, or neurolymphoma, which is the other name for the Schwann cell outer part of the nerve. So the Schwannian outer part, the nerve sheath, is neurolymphoma. If it's the nerve itself, we call them neuromas. And there are a few different types of neuromas. There's acoustic neuroma, there's traumatic neuroma, there's multiple mucosal neuroma syndrome, there's solitary, non-specific, just neuroma, not otherwise specified. And then there's Schwannomas, which incorporate the classic Antoni A and B Schwannomas, and then obviously you also have neurofibromas, which are Schwannian in nature as well. And then you get other cells that have neural differentiation, granular cell tumors. Those are also Schwannian in nature. The cells just basically are making abnormal myelin, and the lysosomal enzymes gets gobbled up by the cells, and they give you that granular cell morphology. So looking at this, we don't see we see some mucin, but not a lot of it. We see mostly these spindle-shaped, delicate schools of fish cells, and we also get this somewhat pinkish bubblegum-like morphology, and that's more characteristically seen in either a schwannoma, not neurofibroma, or possibly a neuroma. And here we also see that these cells are kind of forming these little palisades at the periphery. And it's very well circumscribed. It's got a sheath of normal collagen at the periphery where these cells are probably kind of compressing the collagen. And so this is a nice example, classically seen on the face, of what's known as a palisaded encapsulated neuroma. These are lesions that are not usually taught to dermatology residents. I mean, if you read in the textbooks of nerve lesions, they don't usually have very much written about this. They're usually clinically confused with things like basal cell carcinoma. They're commonly seen on the head and neck area, the face. They usually look like a little skin-colored papule. They may be more superficial than this. They're often seen up in this area. This one's a little bit deeper. And they're usually very small, okay? So it's a nice example of this lesion. So palisaded encapsulated neuroma. Yeah, somebody tried to argue with me and say, well, could this be a schwannoma? And, maybe that's a little part of the original nerve twig that led to it. I doubt it. Those are usually much deeper and larger than this. So I really favor this being a palisaded encapsulated neuroma. It's got the palisaded-like cells at the periphery. It does have this so-called pseudo-encapsulation. It's not really a true capsule. It's just compression of collagen. So again, that's pretty classic, I think, for this entity. Not really critical to get into being a neuropathologist on the derm boards, the derm path part of it, but you should at least understand this lesion. If you biopsy somebody that's got the multiple mucosal neuroma syndrome, the lesions can look very much like this histologically. So if you just saw this alone and they maybe show you a picture of somebody's tongue with a bunch of bumps on it, and they say this diagnosis is most likely blank, well, then I would probably answer multiple mucosal neuroma if you saw something like that. Probably not going to show you a clinical photograph of a little tiny bump on somebody's skin and then show you this and say the most likely diagnosis is blank. They probably wouldn't even ask you this on the exam. But the most important thing is to make sure you know your neural neoplasms and know the differences between schwannomas and neurofibromas and a few of these other entities that we briefly talked about. Okay, let's take a look at this last one here. I think we'll probably have time just for one more. This one's kind of a little bit of a funky one too, but it does make a teaching point. So we've got a shave biopsy here. Again, neoplastic process. In low magnification, we notice there's something going on at the dermodermal junction. There's something going on down here. So when we see this at low power, and it looks like it might even be pigment, we sort of think it might be a melanocytic process. There's some nesting up in this area here. And so just looking at it at low power, to me, the first thing that comes to my mind is a variant of a nevus. It looks small, it's symmetrical, it's well circumscribed. It's got a central component of nests of cells in the dermis. And then to the side, it's got these nest of cells at the dermatodermal junction that are extending beyond that. This is probably the end of it here and the end of it over here. So I think it's only about 4 to 5 millimeters in size. It looks very small, symmetrical, well circumscribed. This looks very much like a nevus to me, and looks very much like a so-called dysplastic nevus. It's got a central dermal and junctional component, and then the what's called the shoulder phenomenon of the nest of cells with some single cells extending beyond the intradermal component with some apical fibrosis around these epidermal rete here. And you've also got some inflammation, a little sparse lymphocytic infiltrate with a few melanophages here. Don't really have any pagetoid spread, don't really have any striking cytologic atypia, don't really have any features that look like malignant melanoma. So to me, this is a pretty straightforward example of a compound dysplastic nevus, if you will. And they might show you this on the exam. They might expect you to tell that this is not a malignant melanoma. It doesn't really have any pagetoid spread. It's small, it's symmetrical, demonstrates all those features that I mentioned to you at low magnification. So again, this is a pretty straightforward lesion. They might possibly ask you some questions that are second order, because once they show something like this that looks pretty classic, then they might say concerns about an individual with a biopsy like this would be potential development of malignant melanoma, if there's a personal family history of melanoma, or something along those lines. So they might expect you to know a little bit about the dysplastic nevus syndrome. They might even show you a picture of someone with a lot of lesions and show you this and say this patient most likely has X. And they might put malignant melanoma down as a choice and expect you to recognize that this doesn't look like malignant melanoma at all. It's a pretty straightforward benign lesion and doesn't really show anything, in my opinion, that would be of any concern for the diagnosis of melanoma here. So this could be a solitary lesion in somebody that has no history of malignant melanoma. It could be a lesion from a patient that's maybe had melanoma before, or maybe he's got a first and or second degree relative with melanoma. So nice example of a compound type of dysplastic nevus, and that's kind of how you approach that. This last example, we'll just briefly go over, shows a nice example of low magnification, inflammatory once again, and it's got the perivascular and maybe periadnexal infiltrate of dark black cells. So the first thing we think about immediately is one of the lymphocytic infiltrates here. And you all know your mnemonic device for the 5 to 8 L's of the lymphocytic infiltrate. I'm not going to necessarily go over those with you this morning, but you should know that differential. You should have it just like the back of your hand. So if you see lymphocytic infiltrate like this, you should be thinking of tumor lupus erythematosus, lymphocytic infiltrate of Yesner, possibly Lyme disease, gyrate erythema. So again, you want to think about lymphocytic leukemia can give you this pattern. So you want to think about all those 5 or 6 L's that can give you this pattern. Polymorphous light eruption with papillodermal edema, we don't see really too much of any of those kind of things. So you always are looking to see what the secondary features are that can help you with the diagnosis. So again, at this power, we just call it one of the lymphocytic infiltrates, or maybe a little bit of mucin here. Maybe this is the tumid form of lupus erythematosus, but you're going to probably encounter this on the exam. They'll probably show you this and expect you to be able to go through this differential pretty quickly and then come up with a differential diagnosis. So basically, that's kind of all you can really say here. One other thing I would kind of throw in the differential we see on occasion is pernio. So if you see this pattern on acral skin, think of pernio. That often give you a little bit of interface change with some papillodermal edema as well. But this is a nice example of one of the lymphocytic infiltrates here. So that's how you do it. Hopefully that's helpful. Feel free to go back and look at this as many times as you want to. And there are lots of other slides in our library. You can kind of go to our website and pull this up and, go through previous unknown sessions, go through these sessions that we're just kind of going through known sessions, guiding you through ways to approach these. So we will see you next month, and hope this is helpful for you. Take care.